Um, Good evening. It's 3:30 sharp, at least on my timing of things. So I think we'll get going. So before that, a few sort of ground rules. It'd be good if everybody else could mute themselves or mute, so that when Dr. Puah Ser Hon is presenting, it'd be absolutely clear. That'd be really helpful. And I know perhaps more people will be joining us in time to come. But it's precious time, and Dr. Puah Ser Hon took off from obviously very busy duties to be with us today. So welcome to the first sort of online CMEs as part of CMEs we're trying to organize for our young doctors here. And it's our absolute pleasure to welcome Dr. Puah Ser Hon, who's been a friend of Sabah. For many of us who've been here before, he was a dear friend, a dear colleague, and he's worked in different parts in Sabah. He was in Tawau for a little while as a medical officer before coming on as a registrar in Queen Elizabeth Hospital. And now he's a consultant in respiratory medicine and critical care in Tan Tock Seng Hospital. And he was part of the lead of the COVID response in Tan Tock Seng Hospital. He's also the sort of lead for the residency program for respiratory medicine in Singapore. And I know some of you all who would eventually perhaps decide to do respiratory medicine. He'd be a good contact, a good link. Perhaps you want to do part of your fellowship program in Singapore. So without further ado, I would like to invite Dr. Puah to share with us the Singapore experience in managing HDW and ICU care for patients with COVID-19 and how to keep mortality low. I'll hand it over to Dr. Puah.
Thanks, Giri. Thanks very much. Thanks for the invite. And my name is Ser Hon, and Sabah really does hold a very special place for me. I worked there for 7 years before I actually came to Singapore to train in respiratory medicine. So it's an unforgettable time for me, and honestly, a part of me still stays in Sabah. The physician I am today, I must say, is credited to my friends there, my seniors, and all my gurus back in Sabah. So they've taught me so much, and I'm sure they're teaching you as much as they can right now as well. And it's really it saddens me whenever I check the situation in Malaysia to see how it's panning out. And I hope you guys are doing well and staying well. Just to correct, I'm not the entire respiratory medicine head, but just my health group, which is the National Health Group. Yes, and of course, those of you who are interested in respiratory medicine, please feel free to contact me at any time. So what I was planning to do is that for this talk, I'm just going to share some overviews. It's going to be kind of tailored towards a little bit more critical care. And I think we can share, I'm hoping to hear your thoughts as well and how you guys manage your cases, and maybe you can exchange some ideas, because I feel personally by now, I think you guys probably have a lot more experience than we did. And I'm just going to share you some of the observations that we had and some of the data that we have collected, and share with you the story of the Singapore response to COVID and what's it like at the beginning for us now. So again, I think our experience is quite similar to Malaysia. I think we were one of the countries first to be hit by the virus after Wuhan, and we confirmed our very first case on the 23rd of January 2020, and within days, we got our first patient in our ICUs. So the numbers, just like in Malaysia and everywhere around the world, slowly crept up. And as you can see, it was just in the double digits, but came April, suddenly the numbers just shot up. And the reason behind this is because Singapore is a bit unique in the way it's structured, because we are quite highly dependent on blue-collar workers, which are foreign in nature. And they are basically the backbone of Singapore, where they actually help build construction, the construction side. They are basically part of construction. They build the roads, they build the buildings, they repair the country in general. And the unfortunate thing is that these guys, they live in close quarters in dormitories. And because you know that COVID spreads really easily. And once a couple of guys just gets it, go back to the dorms, and that just spreads like wildfire. And that's how the numbers suddenly just shot up. How did Singapore respond? We responded in colors. So originally, everybody will be in green, where everybody is happy and peaceful. But when the doors gone yellow or the disease outbreak response system condition becomes yellow, then everybody has to be a little bit more careful, safe hand hygiene and etc. But what happened was we went straight to orange really quite quickly. And then we started closing down schools, we started closing down workplaces, very similar to the MCO in Malaysia. Honestly speaking, the country felt more of a rate because we were all trapped at home, schools were being done at home, but the government still called it orange nonetheless. So similarly to all around the world, what happened was that the numbers kept building up. And then eventually the hospital just couldn't cope with the sheer numbers that are coming in. And at the beginning of the outbreak, we were still learning about it, and we kept patients as long as the PCRs were positive. So we had to decant the well patients somewhere. And what happened was we started building community isolation facilities. So in the past, if you were to come to Singapore for conferences, there are lots of halls that were used for all these conferences. They were converted into community isolation facilities. And then the government very quickly built up facilities as well, so just to house all these well-positive patients. We had nurses, all around that area as well, just to make sure and to keep in touch with all the patients, make sure they do not deteriorate at that place. But most of the time, patients that go there have already been observed in the hospital and deemed to be well enough to go over. So a little bit of the place where I worked in. I work in Tan Tock Seng Hospital, which is a 1,500 bedded hospital with 4 ICUs there, a medical ICU, a neuro ICU, a cardiac ICU, and a surgical ICU. And the respiratory department basically takes care of the medical ICU in Tan Tock Seng and around the country actually. And I think it was really fortuitous that the National Center for Infectious Disease completed building in 2019, you can say just in time for the pandemic. Now, during peacetime, the bed capacity for the NCID or National Center for Infectious Disease up to 330 beds, but they managed to expand it to 586 beds. The ICU capabilities in that hospital alone was up to about 38 beds, but during the pandemic, we have made plans to extend. So NCID and Tan Tock Seng is just separated by a bridge, somewhat similar to what the original old Likas and Queen 2 is now. So it was just a link bridge. We just walk across to go to each other's hospitals. And we had plans to actually merge the ICUs. And up here, we were thinking of increasing the capacity to 188 beds ICUs. And we had plans to go up to 285 beds. And this is only in my center. There are 8 other government hospitals around the country. And they have made plans to double up the ICU beds and their beds as well. So where are we at this juncture since January? So these are numbers reported since the 20th of October. We had a total of 57,887 positive cases then. And we are really fortunate that the large majority of them were discharged well. It's 99.8%. And at that juncture, only 34 patients were still admitted and another 34 were still isolated. We were very fortunate to only experience 28 deaths, out of which 17 died in the ICU and 11 died outside of the ICU for non-resuscitation orders, or because we felt that they were not candidates to come into the ICU. So the overall mortality rate, if you just calculate by crude numbers, it looks pretty good at 0.05%. Now I'm going to share with you some of the observations from a critical care perspective point of view. So, Siddiqui et al. Had a really nice pictorial diagram of how the virus actually attacks us. So initially there's a viral response phase where you get all the upper respiratory tract infections. This is when your lymphocyte starts going down, your PT starts going up, your D-dimers all start going up. Then comes stage 2, where suddenly the host starts responding even more violently against the virus. You start getting more breathless, your PF ratio starts coming down, transaminitis starts coming up. And eventually what happens is, despite the viral phase going away, the inflammatory response just started to take hold and then just goes berserk. And that's when ARDS comes in, shock comes in, cardiac failure and all that. So at the beginning of the pandemic up to now, we are still trying to target where's the best place we can prevent them from actually going on to ARDS. And we may have some answers now, but at the beginning it was really scary, and I'm sure it is still for you guys. So just a really brief overview of ARDS again. So the acute respiratory distress syndrome is basically when an inciting inflammatory agent hits the lung and causes disruption of all its epithelial membranes. And what happens is then the alveolus becomes super leaky, and then all the exudate starts going into the alveolus and starts plugging it up. So from an original well-ventilated alveolus, you get a lot of VQ mismatch, and eventually once it's all flooded with pus and exudates and fluids, then it starts to the shunting starts happening, and then you just can't oxygenate patients. So we have always wondered whether we are actually seeing a typical ARDS when COVID ARDS happens, and I'll go to that in a short while. And WHO has come out with their disease severity definition. So they say mild is for all the URTI patients. Moderate is for clinical signs of pneumonia, but their SATs are okay on room air. And their definition of pneumonia is again quite vague. They actually listed down fever, cough, dyspnea, and fast breathing as signs of pneumonia, but that's just so vague. So when it comes to severe, you have pneumonia plus one of the following, and they actually very clinically define it as respiratory above 30, severe respiratory distress, which they didn't really define what they mean by that, and when your oxygen saturations drop below 90% on room air. When you hit ARDS, that's when it's critical. So on the right, what you see in that pink box is actually the Berlin criteria to diagnose ARDS. And actually, COVID-19 ARDS, or actually the term CARDS, was coined by John Marini. And he's been using the term CARDS quite regularly in his journals and articles. And basically, it is following the Berlin definition of ARDS. But what they have recommended here is that the patient has mild ARDS, meaning your PF ratio is between 200 and 300. You can actually consider using high flow nasal cannula oxygenation, or even consider non-invasive ventilator. We can have a discussion of this at the end, whether these are useful modalities to help patients with acute hypoxemic respiratory failure. Of course, then moderate and severe following the Berlin criteria. So for our experience, it was quite an interesting one, where it was almost like a call to arms for all the intensivists across the country, and everybody collaborated without any problems whatsoever, which is really amazing. When we asked for data, they just say, here, take my data, and they just basically shared with us whatever information that they had. And basically the country almost united just to find out how we can actually help combat the virus at the beginning. And by the end of March 2020, we managed to gather enough data to analyze 50 well patients versus 10 ever intubated patients. And we managed to create this multivariate model to see who we can predict that we actually require an ICU care. And we were trying to see whether we can actually use predictive markers where we can actually identify patients earlier. And what we found in this multivariate model is that the older you are, the more dyspneic you are, the more higher your temperature, the higher the heart rate, the higher the respiratory rate, but the lower the oxygen saturation and lymphocyte count, and presence of X-ray changes, but an increase in neutrophil counts predicts that you need to go into the ICU. And as you can see, the AUC curve on the full model is very close to 1, which was fantastic. Now, this is quite a mouthful. The criteria are quite a mouthful. So we decided to cherry pick neutrophil counts more than 4 and the respiratory more than 18. The AUC curve was again close to 0.9, which is pretty good. I think one of the earlier findings that we realized was that the degree of hypoxemia really didn't correlate with the radiological changes at all. And I think you have seen enough X-rays with COVID to know that they usually don't present with collapses, big masses, or very, very marked consolidative changes. Actually, most of them actually do start off with just ground glass changes, quite diffuse, and they actually look almost like a PJP pneumonia, kind of like of an X-ray radiology. And you can here see some of the CT scans that we managed to get from some of our patients over here. They're really ground glass scattered all over the place. It's quite heterogeneous in distribution and not just a full white-out lung. So then we started collecting more and more data. And by June 2020, early June 2020, 8 ICUs have contributed data in the common pool of ICU patients. And we managed to gather data for 102 ever intubated patients. And this data was collected prospectively. I'm going to share with you what we found, and I thought it was quite interesting. Now, if you look at this table, the first column is by Nicholas et al. He was the author of one of the lung safe paper, and the lung safe paper in this, the one that he published was looking at the difference between males and females, and I aggregated and show you the average in this table over here. Ferrando et al. Actually presented one of the largest descriptive ICU paper with about 700 patients. The Magnicus paper is about 2,300 patients, and this is our tiny islands data at 102 patients. But as you can see, even then, they are roughly the same. So this is typical ARDS. This is a Spanish cohort COVID-related ARDS, and this is ours. And as you can see, the age is the same, predominantly male. Our Apache score is about the same. Now, our OSOFA score is a little bit lower, but it wasn't statistically significant. And we theorized is that because we were a little bit more careful and we brought patients down to the ICU a lot earlier. All across the board, we had moderate ARDS as the predominant presentation into the ICU. And since the day of symptom onset in Singapore, we see them coming to ICU on day 7. I'm not too sure in Malaysia whether you are seeing the same profile that we are seeing here. The plateau pressures, which is a measure of alveolar pressure within the lungs and how stiff your lungs are, is actually not too bad. So anything above 30 centimeter water, mils per centimeter water, is actually considered high. The driving pressure is also on the low side at 12. Now, what is bad driving pressure? Based on Amato's paper, it is more than 15. So if you have a large driving pressure, having to drive air into the lungs, indicating that lungs is very stiff, then it's a bad prognostic marker. And these are all pretty all right. Now, compliance tells you how stiff the lungs is. And it is measured using a ventilator. And you can see they're all pretty much the same at 30, about in their 30s. What's a good compliance level? Anything above 40 is pretty good. So recruitment maneuvers were used quite frequently in Spain. We didn't report any recruitment maneuvers because we didn't really use much of it, and we didn't really document those down. Prone positioning is when ventilated patients were placed onto their bellies to improve VQ mismatching and then improve oxygenation. And as you can see, some of their, you must understand that this is actually prospective data. So at the beginning, we were afraid to prone patients, we were afraid to move patients, but eventually we realized the benefits of proning, which I'll allude to later, and we started doing more and more towards the end, towards the middle of the pandemic. As you can see, the numbers started climbing up, and at June, we prone about 52% of our patients already. The neuromuscular blockade, most of them received it, and about 5% of our patients underwent extracorporeal membrane oxygenation. I think one of the things to highlight, which I think, again, we are very fortunate, is that our mortality rates weren't that high at 15%. And mind you, these are all ever intubated patients. The Spanish cohort also had not too bad mortality rates at 32%, which is actually in keeping with ARDS mortality rates at 30 to 40%. Now, the paper from New York, Italy, and Lombardy, their mortality rates was close to 70 to 80% if you were ever intubated. Those were published early on in April and May. And those are really scary numbers to look at. So it was interesting to see why is there a difference between the both in our patient, whether is it because of genetics, whether it's because the virus have a different strain. It's all up in the air at this juncture. So then why does ARDS happen to patients that got COVID? One of the theories that has been proposed by a whole bunch of intensivists around the world is this thing called PCD, or patient self-inflicted lung injury. So what this means is that, interestingly, patients with COVID particularly have an increased respiratory drive. Whether it's because the virus itself goes to the respiratory centers and stimulates an increased respiratory drive, or whether because a cytokine-like storm actually causes the increase in respiratory drive. And what happens is, if you have increased drive, you tend to draw in a lot more air. And how do you have, and to draw in more air, you need a lot of transpulmonary swings in pressures. So the large swings in transpulmonary pressures and large air going in and out, you can imagine there's a lot of barrel trauma and volume trauma. And so we're kind of blaming it on the patient causing hurt onto themselves, which actually caused the ARDS to get worse and worse. So because patients self-inflicting their own injury, they become more leaky, ARDS is worse, they breathe harder, and this is a vicious cycle. This is one of the theories. Not everybody really agrees on this, but we do see that some patients do take big breaths. So then come whether we can actually phenotype the difference between the ARDS that actually happens in these patients. And Gattinoni and Marini actually coined these two phenotypes called the L and the H phenotype. Now, what's the L phenotype? Everything starts with L. So it's low elastance. And we know that elastance is inversely proportional to compliance. So if you have a low elastance, means you've got a high compliance. So in other words, your lungs is very, very pliable, and it's easy to ventilate you. Despite that, you have a low VQ mismatch. You got low VQ ratio, you got low lung weight and low recruitability because your lungs are pliable. Now, H phenotype, everything is high. You got a high elastance, meaning low compliance, which is typical of usual ARDS. You have a high right to left shunt because most of the alveolus is plugged with pus of fluid. Your lung weight is high because of pus in the fluid. And because they are typical ARDS, some areas in the lungs are more recruitable. If you remember some of the CT scans I showed you just now, they're all ground glass. There's really not much to recruit. That's why those were probably in the L group. Is that true? This paper came about when they actually compared the L and H phenotype versus the CT scan findings, and they found very little correlation between CT scan findings with the L and the H phenotype. So then people started wondering, is it truly different as compared to normal ARDS? And whether this L and H phenotype is really present or not. Now, Gattinoni and Marini, when they discuss about the L and H phenotype, they say that most of their patients, about 60 to 70% of their COVID ARDS patients, actually belong in the L phenotype. The compliance are good, it's high. But around the world, we are starting to notice, actually, we are not seeing a lot of patients in the L phenotype. We are seeing them more of the typical ARDS in the H phenotype. So in our 102 cohort, we actually looked at patients with compliance data, and we managed to extract 67 patients with good compliance data, and we actually had a look at them. And it is not surprising to see that actually most of our patients were in the H phenotype. So it means their compliance are poor, it's really stiff, it's typical ARDS. And because their lungs are stiffer, their plateau and driving pressures were higher. And of course, when we talk about L phenotype, when we say that the compliance is actually pretty good, it shows here in the data where the compliance is good at 50, and we took a cutoff of 40 to divide the L and the H phenotype. And interestingly, patients with better lung compliance had higher mortality in our cohort. Now, the numbers are pretty small, and this is unpublished data. So it's an interesting observation that we see. And then if you do start off with an L phenotype at the beginning, and if your compliance drops in day 7, your mortality rate is higher. It's one of the data that's been shown. So then there are now papers up in the ICU journals is whether we should measure respiratory drive. And now the ventilators are getting pretty good, and we can actually measure drive by occluding the inspiratory pressures at like 0.1 seconds and 0.3 seconds and look at the negative deflection. And they did find that patients with high negative deflection, meaning high swings in pressures, high respiratory drives, fail extubation higher. So that is mainly discussing about the ICU patients. I think one of the things that I didn't put up in the graph is that patients who develop acute kidney injury, and then alluding to patients that require high frequency of higher needs of dialysis. Actually, these two groups of patients, based on univariate analysis, had higher mortality rates as well. So if you've got a patient comes into ICU with COVID-related ARDS and their kidneys are going bust, it's usually quite bad news, and they have a high mortality rate. So midway around April and May, when we started proning patients during ventilation, we noticed a remarkable increase in their oxygen saturation levels. They respond even better than the regular ARDS patients. And because the number of patients kept growing in our hospitals, and most of them do suffer from oxygen desaturation. And at that point in time, I think a lot of data came out with this happy hypoxemia or silent hypoxemia, where patients are hypoxemic with sets going as low as 60 to 70% in the States, yet feeling okay. We started doing prone ventilation, awake proning in the general wards. And the protocol that we use is that patients will prone onto their bellies for an hour, longer if possible, and we will prone them for at least 5 times a day if possible. Of course, each episode, the longer the better. And one of my registrars actually had a nice publication and where they actually did a case series of 10 patients that they did awake prone in general wards. And the median duration is about 21 hours of prone. And usually they started around day 9 of illness. Now, out of the 10 patients that they started proning in the ward, only 1 patient ended up requiring high flow nasal cannula. 2, the highest they escalated to ventimask 50%. But out of that 10, 1 had to be intubated and eventually passed on. So it is something that has been practiced in NCID now. We prone patients whenever they require oxygen, and we start them early. I guess the next question is steroids. To fear it or not to fear it? I think that at the beginning of the pandemic, there was a lot of fear of using steroids. And this is the MERS data by Arabi et al. And they found that actually when they gave hydrocortisone to patients with MERS, the crude analysis of 90-day mortality were higher. And they found that the later they gave the hydrocortisone, based on their presentation, the worse the outcomes were as well. And in Arabi's paper, they alluded to the fact that viral clearance is actually prolonged with steroids. And they found that patients that receive steroids, their PCRs remain positive a lot longer. So a lot of patients, there was a lot of fear giving steroids because of this MERS data. Of course, there are a lot of data on influenza where if you actually do give steroids, there's a higher risk of mortality. The dotted line is patients who did not receive steroids, and the solid line are patients who receive corticosteroids for severe influenza pneumonia. And the GetGag study showed that, as you can see, the blue line is talking about discharge, and the discharge, more patients were discharged if they did not receive steroids, more patients died if they did receive steroids. So with all this data, we all feared using steroids. And to give credit to the physicians in China, they actually decided to give steroids because at that point in time, everybody's still learning about the disease. And whatever they were publishing were retrospective in nature, and they were very, very small numbers. Then came the recovery trial. So the recovery trial was a game changer. In the UK, they were even more amazing by how they all got together, collaborated, and the government just said, you guys are going to work together, collect data, analyze them. And what they did was they actually looked at at about 2,000 patients that received dexamethasone versus 4,000 patients in control in the usual arm where they receive usual treatment, and they were all pretty matched. And they gave dexamethasone 6 milligrams once a day for 10 days or until they were discharged. If you received oxygen, there is a split in the Kaplan-Meier curve, and there is mortality benefit as compared to usual care. If you are on invasive mechanical ventilation, that Kaplan-Meier curve splits even more. So it means there's a higher benefit the worse your oxygenation requirements are. If you do not use any oxygen at all, the evidence of you improving with dexamethasone is a lot less. In fact, if you notice, the colors have reversed. And there may be a signal that using dexamethasone in patients who do not require oxygen may be harmful, although this is not statistically significant. And when you analyze them all, it does show that dexamethasone is better. And because of the recovery trial, many studies were stopped midway. Now, Codex and Dexa-COVID and Cape COVID were ongoing studies looking at dexamethasone and hydrocortisone. And they all stopped early because of the recovery trial. And because they stopped early and they analyzed whatever data that they have, it is taken with a pinch of salt because they didn't really show as marked improvement in mortality rates as compared to the recovery trial. But when they analyzed, when the REACT group published their findings in JAMA, where they used a meta-analysis collection of all this data, they found there is a mortality benefit for patients who receive steroids. 32% versus 41%. They're all in favor of steroids over here. So what about high flow in COVID-19? There's more and more publications coming out on using high flow nasal cannula where you actually receive at least as high as 60 liters per minute of flow rates into the lungs. And one of the earlier papers that came up was by Wang et al. And I think there was 17 patients only. And it was more of an observational study where they actually put it on, and they found there were some improvement in oxygenation, but this wasn't really sustained. We actually had a look at our own patients that were on high flow nasal cannula, and we were split in the middle between those that got intubated after starting high flow and those that didn't get intubated start high flow. Unfortunately, we only had univariate analysis here. We didn't get all the fancy stats. But what we can tell you is that those that got intubated were older. They had worse PF ratios, and definitely the outcomes were poorer as well. They actually had a higher risk of mortality. But what we have noticed here is that this is a nice paper by Geckel, and he looked at 10 patients who are well people, and he actually looked at particles, dispersion particles. And the question that everybody had in mind is that when I put on a high flow nasal cannula or non-invasive ventilator, is dispersion going to be more? Am I going to spread COVID more as compared to something else? So if you notice here, interestingly, in high flow nasal cannula, when you're doing normal breathing, talking, deep breathing, and you're coughing, they're all the same. What was higher in terms of dispersion is that actually if you're on high flow, on a non-rebreather mask, whereas any other forms of high flow that you're doing actually okay. So does it say that this is going to be safe? We don't know, but at this point of time, we have enough data using high flow nasal cannula that shows that this is at least safe enough to be used for patients suffering from hypoxemic respiratory failure. Again, this is a nice data showing our patients that received prone of 20 patients with ARDS, and we actually showed that actually after proning, there's an increase in PF ratio and improvement in CO2 2 hours after proning. But the problem is once we put them back on supine, this protocol we followed the ProSeva trial where we actually prone patients for about at least 16 hours, and then we unprone them again, put them back on the supine. And we found that, unfortunately, the oxygen saturation improvement and PF ratio improvement didn't really improve that long. So we had to keep proning them eventually. Something to share with you is that once they actually survive and come out from ICU, we actually noticed some patients actually desaturate when they ambulate and we do physiotherapy. One of the interesting phenomena was this platinum autodeoxia syndrome in our COVID-19 ARDS patients, where patients actually desaturate when they sit up. When they lie down flat in supine, the saturations improve. So as you can see, this is a continuous ward monitor for one of the patients, and the blue line is basically the oxygen saturation, where it suddenly dipped when he started sitting up, and then it improved immediately once we lie them down again. Now, if you see this, most people will be worried to do physiotherapy for them. They'll be worried to do rehabilitation for them. And this is because they do desaturate quite profoundly to close to 80%. And there were a couple of patients we even thought of bringing down back to ICU, but when they lie down, their sets improved to beyond 92%, and we decided to observe them in the wards. So why is there a positional change? The suspicion is that potentially there's actually a gravitational redistribution of blood. And one of the theories why COVID-related ARDS happens, why happy hypoxemia happens, is because not just that there's thrombotic events, microthrombotic events within the lungs that causes VQ mismatch. There's also abnormal vasodilatation of the pulmonary vessels as well. Now with this mismatch in vessels, then what happens is then there will be a shunt effect and increased venous admixture, leading to the desaturation episodes. Now, when you sit up, what happens is there's also reduced venous return, and then there's also reduced cardiac output. With that, there's a stimulation to the respiratory center because of the reduced cardiac output, hence increased rapid shallow breathing, and then increased dead space ventilation, and then leading on to platinum autodeoxia syndrome. So watch out for desaturations in the general ward, which we have noticed in some of patients coming out from ICU from severe COVID ARDS. So I'm just going to summarize some of our observations again. So we prone patients, and we prone patients quite early on, even in the general ward. As long as they're on oxygen, we'll start proning them. And there were some anecdotal stories where the patients were so comfortable when they prone, they felt much better, that even when they were off the oxygen, they started proning themselves, and they flipped up their iPads and they flipped up their phones and started watching their movies while on the prone position. At this juncture, our practice is to start dexamethasone early. As long as the patient's on oxygen, we'll start them on dexa. If that oxygenation doesn't maintain, our threshold to start high flow nasal cannula is low, and we start them high at 60 liters per minute, and then we titrate on FiO2 accordingly. We monitor for deterioration. If the prone fails, our need for intubation will be higher. There's increasing FiO2 requirements, drowsy, and tachypnea. And when we manage patients with ARDS in the ICU, we're using the same principles of ARDS management: 6 to 8 mils per kilotide volume, keeping the plateau pressures less than 30 and the driving pressures less than 15. But instead of a higher PIP, we may want to use a lower PIP because some patients actually do have quite good compliance. We still paralyze them during neuromuscular blockers and also proning them when the PF ratio is less than 150. And if all fails, we will refer them for ECMO. NCID is not an ECMO center, so we actually have to borrow services from other hospitals to do the ECMO for us. So once they improve, we will try to bring down the FiO2 quickly and PEEP, and then try to get them off the ventilator as soon as we can. I think the complications to look out for, and I'm sure you guys see it quite often, is hypotension, where they actually get, it's maybe medication related. We noticed that if they were hypotensive, it's at the beginning of the intubation. So immediately after intubation, what happens is they are hypotensive, requiring vasopressors for that short period of time that is taken up. Then later on, if they require vasopressors, what happens, we suspect then that's a secondary infection that come on board. They're usually quite dehydrated because they're actually breathing quite rapidly. And whether there's concomitant sepsis. There's a higher incidence of venous thrombosis reported around the world. We haven't really seen that in our setting. I'm not too sure about whether you guys see a higher risk of venous thrombosis or thromboembolic phenomenon. We had a couple of patients that actually developed a pneumothorax and requiring chest tube insertions. Cardiac complications is apparently quite well described these days. They develop myositis. They actually get raised in troponin eyes. And again, the acute kidney injuries are the patients that don't do too well. So look out for this group of patients. How have our practice changed from March to today? We prone them earlier. And again, as mentioned before, we use a lower PIP, and we actually use more high flow nasal cannula. And at this juncture, we definitely give steroids. So in conclusion, most of our patients actually come in with low compliance, means their lungs are a lot stiffer as compared to some of the reports from Gattinoni from Italy, where the compliance was actually a lot higher. And our mortality was definitely higher if you started off with high compliance, which then progressed on to low compliance over time. Prone works, just prone early, it's free. And platinum autodeoxia syndrome may be present in some of the patients. Just watch for it because that will hamper rehabilitation and physiotherapy. This is a nice summary by Jason Puah, the Lancet Respiratory Medicine, on what to do in patients with ARDS, and he talks about his thresholds to use NIV and use high flow nasal cannula, and then of course whether you need to go full PPE. How to intubate the patients, where you actually use full PPE. Try to avoid back mask ventilation so that you don't cause aerosolization. When you intubate them, you limit the volumes and the pressures. Prone them early possible, and then if all else fails, use ECMO. Now, the only thing that needs to be updated from this flow chart is the fact that here is written avoid routine use of corticosteroids, because in these respects, patients who are now hypoxic, we would recommend the usage of dexamethasone. With that, I end my sharing session. I'm happy to take questions, and I'm happy to hear your experience and whether are you guys seeing similarly to what we have been seeing thus far. Thank you.